Welcome everybody to the next of our series of webinars on the COVID pandemic issues and approaches. And we have a terrific lineup today, as we hope always to do. Let me begin, if I may, by sharing just the orientation to the website and the information about our program, as we always like to do. And we'll have that up and show it to you now. Hopefully you see the URL for our website. This is where we keep updating and providing current information, and as well as other features that we share with you. This is an indication that on this homepage of the website, you can find links to YouTube recordings from our previous sessions, and some of our speakers have also provided their slides. We've made them available on the web, and that's where you can find them. We also encourage you to sign up for our mailing list. We send reminders and announcements of who the next speakers are. During today's webinar session, if you have a question you would like to forward to any of our speakers, please write it in the Q&A facility. It should be at the bottom of your Zoom screen. We'll hold all the questions till the end of the session. We don't always have time for them, but we hope to on any given day, and we'll read those some of those questions to our panelists today. We have a new panelist, and then we have some returning panelists today. Our first speaker is Professor Kyle Meng, who is multiple appointments in the Bren School of Environmental Science and Management, as well as the Department of Economics at UCSB. He's an economist with training in engineering and atmospheric sciences, and he examines environmental and resource economics with a concern about climate change's impact on human behavior and policy implications. He's going to discuss today whether ultraviolet radiation decreases COVID-19 growth rates. Will there be a seasonal effect? Will it be favorable? Then we welcome back at that point Dr. Lynn Fitzgibbons, who's at Cottage Health in Santa Barbara. She's a specialist in infectious diseases. She'll be describing today background and criteria for clinical diagnosis of the SARS-CoV-19 infection. And then we welcome back again Dr. Carolina Arias, an assistant professor in molecular, cellular, and developmental biology at our university, who will be discussing with us today a new low-cost field deployable test for the presence of the COVID-19 virus. So that's enough introduction. Let me turn the screen back over to our participants and ask Professor Meng to tell us about seasonal effects on the COVID virus.
Thank you. Joe, can I just get a quick thumbs up if you can see my slides? It's good. Okay, great. Thank you very much. Thank you, Joe and Andrew, for organizing the seminar series. I'm delighted to present this work with you. Just a little bit of background. I'm an assistant professor. My primary appointment at UCSB is at the Bren School of Environmental Science and Management, and I also have a dual appointment at the economics department. I'm an environmental economist. I have spent much of my scholarship trying to understand the consequences of climate change, as well as the design of climate change policy. So on the policy end, I do a lot of work here in California, thinking about climate policy here, but also at the national and global level. A good chunk of my scholarship actually has to do with trying to bring in kind of big data empirical tools to try to understand what climate change would do to socioeconomic system outcomes such as civil wars, to ecological productivity, to labor productivity, a whole host of outcomes. And that's actually the starting point for this study, because what you're going to see is a study that has some social science and economics in it, but actually is largely trying to get a pretty core kind of epidemiological question regarding COVID. And what we're going to bring is a whole series of tools, empirical tools that we've been using actually in the climate impacts domain into this question, because we think there's a lot of kind of potential here for cross-fertilization. So this work is joint with a wonderful team. Tama Carlton, is a scholar who just finished a postdoc at University of Chicago, and actually will be joining us at the Bren School in a month's time. She's an environmental economist. Jules Cornetet is a PhD student from Paris, also an economist who's visiting the Bren School as a pre-doc scholar. Peter Hoybers is an atmospheric scientist at Harvard on the faculty there. And then Jonathan Proctor is an economist who is working as a postdoc currently at Harvard. So what's the motivation for this study? This is a map of, at a country level, many of you have seen this before, but basically the spatial extent of COVID-19 to date. As of this very moment, there's about almost 5 million confirmed cases globally, and it is very much a global pandemic in the sense that COVID has now been detected in over 185 countries. There's scarcely a corner of the planet right now that hasn't seen some cases of COVID, with a few exceptions being maybe like Greenland. But there's also been a very interesting spatial pattern to date. What do I mean by that? If you see the kind of, if you look at this map kind of carefully, and you kind of focus on the areas that have like darker colors, they mostly reside in northern latitude, or what we would call kind of boreal locations, upper extratropical locations in the northern latitude. We are seeing cases in the southern hemisphere, south of the equator, but we're not seeing as many. And the reason why this is interesting is that we're kind of interested in the question of what will the spatial pattern of COVID look like, not just right now, but in the next few months as the boreal summer arrives in the northern hemisphere, but then the winter at the same time arrives in the southern hemisphere. But then on top of that, when the kind of winter returns in the northern hemisphere, how would that kind of change spatial patterns once more? And of course, the motivating reason for this is because a lot of environmental conditions, local environmental conditions, exhibits very strong seasonality. So here are just maps at a very high resolution around the planet showing average January on the left column and average July, right column, UV exposure, UV radiation, top row, temperature, middle row, and specific humidity on the bottom row. What I want to impress upon you is that there is, for these variables, very well established and very distinct seasonality, in the sense that in January, where around the time of the winter solstice in the northern hemisphere, UV exposure is lower than it is in the southern hemisphere. And of course, this pattern flips when we enter into the month of July. And that drives a lot of local environmental kind of seasonality as well, and the spatial pattern of it. It drives the spatial pattern, the very distinctive spatial pattern that we see in seasonal temperatures, shown in the middle row, and then also in specific humidity. So the question that we're interested in is, whether or not, trying to answer empirically whether or not COVID-19 is seasonal. And if it is, that would predict quite a dramatic change in the spatial footprint of COVID-19 globally as we kind of ramp up towards the summer months. But then, of course, that would then change thereafter as the winter months return to the northern hemisphere and then differentially in the southern hemisphere. There has been a lot of work on this. If you look at, just kind of go to medRxiv or bioRxiv, just kind of put in the word seasonality, you will find many, many papers. And so what we're trying to do is trying to contribute to this, this kind of what we think is a very important question, using a series of tools that has not been brought to bear to date. So what is the prior evidence of this? There's been a lot of work on previous viruses. So there's been a lot of work trying to understand whether or not influenza, your kind of typical flu, exhibits sensitivity to local temperature and specific humidity. And the general sense from that literature is that it does. But at the same time, if you look specifically at prior kind of related coronavirus strains, so such as SARS from 2003 and MERS from a few years ago, a bunch of studies suggest that these coronaviruses kind of related to what we're seeing now are not very temperature sensitive, but they do look like they are UV sensitive. Of course, these are prior studies. We're talking about a different virus to date. And what we're going to try to do is try to bring new evidence to this question for COVID-19. What are the empirical challenges? Well, there are two that we want to highlight and that our study is designed to kind of address. The first is that if you really want to think about seasonality, it's not just looking at one particular environmental condition, but you have to think about jointly multiple environmental conditions. So I showed you in the previous slide, UV exposure, temperature, and specific humidity. All three are correlated locally. When it's hot, it's because it's driven by higher UV exposure. And that correlation means that you have to, in an empirical setting, jointly account for all those conditions. Simply looking at one without accounting for the other might lead to misattribution of a particular variable due to some other correlative influence. The other is that local environmental conditions tend to be very correlated with socioeconomic confounders. What do I mean by this? If you look at places that are relatively richer in just a cross section, so just going from, for example, the equator up to the northern hemisphere, you see a very clear temperature gradient. At the same time, you also see a very clear income gradient. As you move further up north, countries tend to be wealthier, and that in turn means that they have better healthcare systems, maybe better access or better ability to test affected individuals and so forth. And so all of this means that we're kind of, if you want to think about it in the kind of shorthand way, we're in a world where simply running correlations across space, across locations, across space, is not going to necessarily lead towards a causal interpretation. So why do I emphasize this? Up to this date, most of the studies that you see using observational data trying to understand whether or not COVID is seasonal have been basically been built off of cross-sectional comparisons across locations. So again, a comparison saying, well, let's compare the US to Mexico, for example. US tends to be cooler than Mexico. Do we see a difference in growth rates or transmission rates of COVID? Now, of course, that comparison is problematic because US and Mexico are different for all kinds of reasons, and a lot of it having to do with wealth and income and socioeconomic kind of conditions. We're going to try to address that. The second issue is that the prior literature has focused primarily on temperature and specific humidity. This is just a subset of the variables that we think vary seasonally. And the UV effect, whereas there's a strong kind of biological emphasis on it, the fact that for the basic reason that viruses are built of nucleic acids, RNA and DNA strands, and both of them tend to be very sensitive to exposure. There's been a lot of kind of hypothesizing about a UV effect because of that biological mechanism, but it actually hasn't been studied systematically to date. And so just to emphasize, there was a recent National Academy review that looked at this whole question about whether or not COVID is seasonal. And their conclusion was that, well, we don't quite know yet. That is, there's a lot of confounding factors. That is, geography is correlated with temperature, humidity, and that those are correlated with public health and healthcare systems, the quality of them, and income. So there's kind of this concern about socioeconomic confounders. And so the conclusion from this recent Academy review is to say, well, we're not there yet, and then there's also some data issues. Okay, so what do we do in this paper? I want to focus on two contributions that we make. The first has to do with data. So I showed you before in the beginning of the talk a slide showing you what COVID cases look like at a country level. So many of you who follow this space have been on the kind of Johns Hopkins University dashboard where they're constantly keeping track of COVID cases at a country level. When we're trying to understand how local environmental conditions affect COVID cases, country level is not good enough. Having a single temperature variable for the US is not good enough given the amount of heterogeneity there is in different climatic zones here in the US. So to really answer this well, you need to get as spatially disaggregated data as possible. And it turns out there isn't a go-to place for that kind of data. Every single country and their reporting agency report their own data, but they're not in harmonized form. They're all found in different places. One of the kind of big kind of push that we did in this project is to assemble what we think is the most spatially fine data set out there for COVID cases. And it's at a daily level. What do I mean by spatially fine? Rather than just having 185 countries for the world, we have over 3,000 geospatial units that we've gathered across the world that covers 173 countries. But that means for the US, we have all US counties, but we also have all Chinese provinces. We have all South Korean states and provinces. We have Italian states. And so where we can, we have subnational data at the finest scale possible. This data set goes from January 1st to April 10th, and it has over 1 million confirmed cases across the world. And it's been harmonized in the sense that a lot of these different countries report this data in different form. And so we've had to go in to try to make them kind of speak to each other in a uniform manner. We're going to pair this data with a climate product that produces UV exposure, temperature, specific humidity, and precipitation at a very fine spatial scale, 0.25 by 0.25 resolution, that's reproduced by a climate model run by the climate weather forecast in the European Union at near real time. That is, we're getting weather realizations at a grid scale from a reanalysis product coming up to 5 days to the present. And this is coming from this kind of state-of-the-art climate model called ERA5. Here's what our data looks like. This is the spatial coverage. So you can see here the map of countries, but you can see also in the zoomed in areas that for a lot of countries, like for much of Europe, South Korea, China, Brazil, Chile, and Iran, we have subnational data. Here's what the temporal coverage looks like. You can see on the horizontal axis, basically January to April, you can see kind of different continents, countries in different continents coming in, and how much coverage we have for much of the world. So by the end of the sample, we basically have all 5 continents, 173 countries, and much of the world population covered in our data set. What is our second approach? This is a kind of a regression equation, but let me just walk you through what our approach is. So rather than doing the kind of cross-sectional comparison, saying comparing US to Mexico, what we're going to do is basically compare populations in the same location over time to itself as environmental conditions fluctuate. So for example, we're going to compare COVID cases in Santa Barbara today to COVID cases in Santa Barbara yesterday and the day before, as kind of UV exposure in Santa Barbara changes relative to the mean of Santa Barbara and a linear time trend. So we're not going to be comparing across locations, which we worry about for them to be confounded, but we're really using daily random fluctuations in environmental conditions for the same population. We're going to also, because we have such a kind of large panel data set, we're going to estimate what's called a distributed lag model. What do I mean by that? We're not going to just simply say, well, what does UV exposure temperature today affect COVID cases today? We notice a built-in delay of about 1 or 2 weeks between when transmission occurs to when it is detected by testing. We can take our data and actually ask, using time lag model, how exposure today to UV exposure or to UV radiation affects the growth rate, the change in confirmed cases of COVID up until 2 weeks later. And so we show in the paper that there's an interpretation from a kind of a standard epidemiological model from the SEIR model that our statistical coefficient on kind of COVID cases in the past on growth rates in the future can be interpreted as a lower bound on the total effect of environmental conditions on COVID transmission. So let me walk you through our main results. Here, what I've plotted for you is on the left, our UV effects, middle temperature effects, and specific humidity effects on the right. Each coefficient or each kind of dot you see is a lagged effect. So the first one in the UV is the effect of UV 0 to 2 days before present, 3 to 5 days before present, all the way up to 15 to 17 days before present. What we see very clearly with UV is that there's a very pronounced lagged effect that kind of reaches a minimum about 9 to 11 days prior. That is, UV exposure 9 to 11 days previously lowers the growth rate of COVID cases into the future. In temperature and specific humidity, we do not see as pronounced an effect. We see kind of for temperature, a kind of a negative effect about 2 weeks before, but all the other kind of lagged effects are not statistically significant. So focusing on our UV effect, you can just take the sum of all those coefficients to basically get at the total effect of a single day of UV exposure on the next 2 weeks of growth rates. So what do we find is that a 1 standard deviation in daily UV exposure reduces the daily growth rate of COVID-19 exposure, this average across the world, by 1.3 percentage points. How much is that? Is that a lot? Well, if you look at our sample average of daily growth rates increases, that is 13%. So a 1.3 percentage point increase or decrease relative to a baseline of 13 is quite large. Members of the epi community like to think about sometimes doubling rates, so you can also kind of convert this into how quickly COVID doubles. And so we're basically finding a 1 standard deviation increase in UV leads to a doubling of COVID cases from 5.25 days to about 5.82 days. Okay, we can talk about a bunch of robustness checks that we do in terms of our statistical model, but let me focus on the following in my final few minutes. We're interested in understanding how these statistical estimates impact seasonality over the next 11 months. What I've plotted you here is on the horizontal axis months, and on the vertical axis average UV exposure for the extratropical northern hemisphere. So this is locations north of 23 degrees latitude in red, and extratropical southern hemisphere locations below 23 degrees south latitude in blue. You can see this is a very clear kind of seasonality in UV exposure that's basically driven by the orbital cycle of the planet. That is, in July, there's more UV exposure in the northern hemisphere, and that reaches a minimum during the winter solstice, what we call the winter solstice. And then, of course, the effect is flipped, right, as the Earth's rotation flips, or kind of the kind of angle of the Earth relative to the sun flips for the southern hemisphere. So what does this mean when we take our statistical estimates and then project the forthcoming changes in seasonal UV exposure? Let me just focus on the kind of map on the upper left. This is what we kind of, as an illustration, what we forecast is the change in the daily growth rate of COVID growth rates from April to July. Okay, July being the kind of peak of the summer solstice. And what you see is in areas in blue are places they're going to see a drop in exposure, a drop in COVID growth rates as a result of lower UV exposure. But places in red are places that are going to see an increase in UV exposure and therefore, a drop in UV exposure and then therefore an increase in COVID growth rates. And of course, this is temporary because by the following year, this effect flips. So that's what's being shown in the bottom map. Places now the northern hemisphere are in red, showing kind of increased COVID growth rates. Places in blue are in the southern hemisphere. We can show this in a different way. We can also just kind of plot over the course for every single month over the next 11 months for every single country what we forecast COVID-19 growth rates to be, driven only by UV exposure. Now, we want to be very careful here. This is not a literal forecast of seasonality because we're only changing the UV component of seasonality. We're not changing temperature, we're not changing specific humidity, we're not changing precipitation, in large part because those other components we do estimate, but they're estimated very noisily. So the only clear signal that we get right now is in terms of UV exposure. And so we can't quite say that for sure by July, we think that COVID-19 growth rates are going to fall in the northern hemisphere because temperature and relative humidity are going to be changing together with UV exposure. But if you just look at the UV effect by itself holding everything else constant, it is very large. So for example, looking at the line in blue, which is the average effect across countries in the northern hemisphere, what you see is, that's the line in red. What you see is a fall in the COVID growth rate in July relative to today, about 4 percentage points. How big is that? In the northern hemisphere right now, the average mean is 13%. Okay, so 4 percentage points off of 13 is very large. And then similarly, a very large increase in COVID growth rates in the southern hemisphere. And again, afterwards, the effect flips because of seasonality and the way the solar insolation is going to change moving into the winter boreal months. Okay, let me just quickly conclude. What we find in this study, using a global data set of COVID cases that we built specifically for this paper, which we're happy to share for anyone who's interested in. In fact, the data set is publicly available. At this point, we've posted it. Is that we find that that COVID transmission rates is highly sensitive to UV exposure. This suggests that we're going to expect to see a shift in the global spatial pattern of COVID transmission in the coming months. Northern latitude places will see a fall in COVID cases, but then that fall will kind of lead to a rise again once the winter months come back. And then of course the southern hemisphere, which today has seen fewer cases, looking only at the UV effect, should expect a larger increase in COVID cases, followed by a drop thereafter in the winter months. We want to emphasize that at the moment, our understanding of temperature and specific humidity effects is incomplete. The estimates that we have are very noisy, and this is a case where we think future research and more data would be needed. Finally, what do we think are the policy implications of our study? We think that what this suggests is that COVID-19, just as previous coronaviruses, looks to be quite seasonal, and in particular, seasonality here defined as being sensitive to UV exposure, suggests there's an enhanced case for kind of COVID-19 containment policies in the southern hemisphere. But in the northern hemisphere, like where we are, it doesn't mean that we should take the foot off the pedal, but rather what we're going to have in the upcoming months is a window of opportunity. Basically, that is a window of opportunity to build up testing, to build up kind of capacities, public health capacities, and so forth, to basically prepare us for what could be a increase in COVID transmission rates with the arrival of the winter months come September, October, and November. And this is important because there have been many kind of past viruses where the sense was that the second or third wave of the viruses, in particular with the kind of Spanish influenza of 1918, turned out to have been quite as large, if not larger than the first wave. And so this is something that Northern Hemisphere locations should prepare for. So thank you very much, and look forward to your questions.
Joe, this is Lynn. I take it I'm on. Okay, I will take the screen. All right. Thank you, Kyle. That was fascinating. I think, as many of you know, my name is Lynn Fitzgibbons. I'm an infectious disease physician, and Carolina Arias and I are going to talk today about testing. In the wake of that excellent talk, I think the testing is, of course, very, very fundamental to how we are going to know when that second wave occurs, and really the magnitude of it. I think at a very, very fundamental level, everything up till now and everything going forward, I think really relies on this. And so I think Joe Ambush and the other organizers of this great series have asked us to just go through some of the background to testing, clinical testing, but also talk about an exciting project really led by Carolina and her team. So some of you know all of this, some of you may not, but I wanted to speak on a very fundamental level about our testing for the virus SARS-CoV-2. Remember that the real basis for diagnosing this infection is in the reverse transcription polymerase chain reaction, the RT-PCR. We are doing these PCRs on the clinical side on swabs that have most of the time been collected from the nasopharynx. The nasopharynx is going in through the nares, through the nostril, and actually going as far back as the back of essentially the throat. So a deep swab, as well as other respiratory tract specimens from the back of the throat, from the oral pharynx, the back of the oral cavity, or even saliva. The PCR itself is targeting a variety of genes. So there are different products. People have heard some of the commercial labs perhaps being talked about, whether it's Abbott or whether it's LabCorp, Sonic, Quest Diagnostics. There are, of course, now many, many folks in the RT-PCR game. Again, we're certainly benefiting from those developments. But many of these different tests are targeting different antigens, different gene targets. You see them listed, but a combination between the envelope, the N, the nucleocapsid, the spike, the polymerase itself, or the ORF1 gene. I'm only going to speak for about 5 minutes and then hand the floor over to Carolina. And I'm really going to delve into this just absolutely phenomenal article in JAMA a couple of weeks ago. This is really a cartoon, a model of what happens to the clinical diagnostic tests, the tests that we do to really confirm, look for disease in a patient with this infection, with COVID-19 disease from SARS-CoV-2 virus. And here you see in the black dotted line at this point in time, this is the moment that this patient fell ill with COVID-19. And before the patient developed any symptoms, they were in what we call the pre-symptomatic period. At some point in those preceding 2 weeks, we know that they were exposed to this virus and they became infected. And then a series of events occurred within their body. And at some point, they started developing virus and active replication of virus, such that their nasopharynx, if it was swabbed, and this is, of course, these are ranges, these are estimates and cartoons, but let's say a few days to perhaps a week before, at a very low level, the RT-PCR was starting to turn positive, peaking within the first week after they started developing their symptoms. The detection of the PCR before someone develops symptoms is unlikely, although we now know from models, including an important Nature Medicine article from about 3 weeks ago, that if we had the knowledge that a patient was to become symptomatic at a certain moment in time, if we were to look back on the preceding 24 hours, there's perhaps a 50-50 chance that we would find a positive PCR in that exact time period. So again, this idea that people do become detectable by PCR prior to the onset of their symptoms. They remain PCR positive, again, the blue being the nasopharynx PCR. They remain positive for, on average, perhaps between 2 and 3 weeks. Yes, perhaps even a little bit over 3 weeks in some studies. They then at some point stop having a positive PCR, and overlapping with the fall off of the virus, we see that the antibody starts to be produced. And so here with these dotted lines, I'm showing you, or this JAMA article is showing you the serologies. Where does the IgM start to be produced? It's really in that second week of illness. And the IgM, of course, is the antibody that is produced first and falls off first. The IgG, of course, in green here, again, rises just a little bit more slowly and is there for a much longer time period, usually over months, and in some diseases, of course, for years and longer. Most patients who have symptomatic COVID-19 disease, as I mentioned, will become positive before they develop symptoms. And again, it's peaking for the most part in that first week, and usually declining by week 3. Critically important piece to remember as we think about positive PCRs, as we're looking at data, for example, a correctional facility that has many hundreds of cases. The question is, does that positive PCR correlate with viable virus, with actively replicating virus? And the answer is, of course, not. RNA degrades quickly, and so at some point in the recent past, there has been actively replicating virus. But it's a subtle point, but an important one clinically, and a very important one related to infectivity, to remember that just because someone has a positive PCR doesn't actually correlate perfectly with them being infectious or having actively replicating virus. I think we've all heard these stories, but there are reports out to 42, 44 days for some people still having a positive PCR. There are also increasingly cases where there may be intermittent viral shedding, where a patient is positive, PCR positive, and perhaps sick, and then they get tested and they have 2 subsequent negative PCRs, but then they subsequently, after the 2 negatives, revert back to positive. And this is, of course, very problematic on the clinical side. What to do with that intermittent viral shedding? Should we continue to isolate those people? Should we not? And how do we decide? There was an important study very early on in this epidemic, about 2.5 months ago now, of 9 patients, where they attempted to isolate the virus and culture. This question of, okay, so these patients are PCR positive 3 weeks out, but how long can we actually culture a viable, actively replicating virus? And these researchers for this tiny study said, well, probably not past 8 days. And that's, again, where the CDC finds its foundation for the return to work for a healthcare worker 10 days after the onset of symptoms. The idea is that if your symptoms begin on day 0 and you get better, and your fever has gone and you really are on the mend, if not, very close to completely resolved by 10 days, then the thought is you are very unlikely to be infectious. A famous study I think we've talked about, I believe I mentioned during the first talk, but a landmark study with regards to this epidemic was from China, looking at 205 patients who were positive in some part of their body, and all the specimens from these 205 patients were compiled. And this is where we get the number 63% for the nasal swab with regards to sensitivity. They looked at, of all the specimens for these patients who clearly had disease, what percent of these different collection types were positive. And this is, again, it was originally touted as a study that demonstrated sensitivity, But now that we know what we know about this disease with intermittent viral shedding, also variable shedding of the virus in different body parts at different points in the disease course, this data may actually indicate more of the latter, that there is just variable viral shedding. And even in a patient with confirmed disease, when we go looking in different places, we may or may not find it. As I mentioned, when we go looking, we may not find it even with disease present, and the idea that false negatives are certainly a big concern. We do think that the specificity is excellent, again, related to people like Carolina and her colleagues, the virologists who have designed the primers specific for the SARS-CoV-2 virus. But with any PCR, we are certainly prone to reagent contamination and technical errors and potentially false positives. So where can we get PCR testing in Santa Barbara County for those of you who are local? For many, many weeks, in fact, now almost 2 months, some medical offices and clinics have had collections on site. But the challenge whenever you collect a test for SARS-CoV-2 is, of course, making sure that the person collecting is protected themselves. And so with the shortages of PPEs and with swabs have also come shortages of collections. PDL has a collection site adjacent to Glida Valley Cottage Hospital that requires a doctor's order. And then, of course, exciting news here, but also around the state of California and in many other states around the country, is the rollout in our local area, just in this last 10 days, of community-based testing. This idea that a partnership between our local health department, the state of California, and the testing task force, led in part by Dr. Charity Dean, and OptumServe partnership has community-based testing, which is open to the public and of no charge. So again, just to remind you, we've talked thus far about PCR, but just to mention quickly serologies, the antibody tests that come up on average during the second week and have had a lot of attention. Remember that serologies and antibody tests are a blood test, and this is different, of course, than checking directly for the virus in our respiratory secretions. But this is looking for evidence that someone's body recognizes SARS-CoV-2. The idea that if I check antibody tests for chickenpox virus in my blood, those antibodies are going to tell you whether or not my body, my blood, my immune system recognizes the varicella virus as something it's seen before. This is the concept behind antibodies. An antibody that is positive is, again, just evidence of recognition. We use it often as evidence of protection, but to be clear, a positive antibody is simply demonstrating that someone's immune system recognizes a pathogen or an antigen. Serologies are tremendously exciting with regards to this epidemic because they have the potential to help us really inform policy and risk stratify within the population. The problem, though, as I've mentioned, is we do not yet have any assurance that a positive antibody equals protection. We worry about false negatives, particularly early in the course, early after someone has had the infection. We worry that they may not have high antibody levels. But I think my biggest concern, and what I hope you remember about serologies, is the huge risk of false positives. When you have a disease with low prevalence in our community, as you really have around the United States, yes, we've had a raging epidemic, and yes, we've had millions of people now infected with this. We still, as an average population in the United States, have relatively low prevalence. And no matter how specific a test is, when you roll it out in a community with low prevalence, you end up risking false positives. And thinking through the implication of a false positive, if I was to tell someone who has a positive antibody test that they are in some way protected against SARS-CoV-2 infection in the future, that of course runs the risk that their antibody test was a mistake, was a false positive. But as I've mentioned just a couple of minutes ago, it also raises concern for what does confer protection. Just because I actually had this infection and now have a positive antibody, does that mean I'm actually protected going forward? Just this past weekend, we've had now countless examples of concerns raised, the flags raised, related to sailors on the Roosevelt ship. hundreds of people in South Korea, as well as many other anecdotes around the world, in Europe and elsewhere, where we have people who had illness, who had a positive PCR, who got better. Many of the times were actually negative by PCR subsequently, and then have reportedly fallen ill again. I think it's too early to really talk about this reinfection risk, but I think it's an important question with regards to how are we going to use our antibody results. Just the concept of herd immunity, that if this person is infectious and this person has antibodies and is protected, then if everyone in here does not have, the light blue, does not have protection, then of course the virus spreads easily. Herd immunity again, if most of the people in this community is blue, is darker blue, because they have antibodies and they are protected, the person at the front who is infectious cannot infect the people in the back. Again, the concept of herd immunity. And this is, again, the promise of serologies. There's a lot of language thrown around with regards to federal regulation of diagnostic lab tests. Remember that the FDA really provides this regulatory oversight of diagnostic lab testing in the United States. The usual approval process is very thorough. It's longitudinal, it's very involved. Related to really the magnitude of this public health emergency, the FDA is issuing emergency use authorizations prior to that full review and approval. And this is really to accelerate and allow for more widespread lab testing. This process is less rigorous, but it still involves an expedited review of all submitted documents, including the pre-approval activities. And as of last week, there were 12 serologies that were available by EUA, 1 antigen by EUA, which I'll mention last, and dozens of PCR and other version molecular EUAs. Remember that CLIA is another word thrown around a lot. CLIA is essentially the regulation of clinical labs. These are labs that have to meet certain quality standards so that they can test for disease or test for prevention of disease or other tests of health. And this is a regulatory, this is different than FDA approval. This is the labs themselves. How are they qualified to really deal with human health? And it's really under this, this CLIA regulation. There are some small point of care tests. Think of a pregnancy test, for example, that can be done, or other simple blood tests that can perhaps be done outside of a big official lab. And these are called CLIA wave lab tests. But these carry, in theory, lower risk of incorrect results, and that's why they can be done outside of big certified CLIA labs. So let me mention lastly, antigen testing. So exciting news last week, or now it's been 2 weeks, 2 weeks ago, the FDA authorized a new type of test. So this is different than serologies, different than antibodies, and also different than PCRs or molecular tests. This is the first rapid antigen test. And this was a company out of San Diego. And they received authorization to do nasal or nasopharyngeal swabs directly or after storage in viral transport media to look for the antigen of the nucleocapsid protein that was present in the acute phase of infection. And the exciting part was that this was authorized by the FDA, not just for CLIA labs, but also for point of care, CLIA waived labs. The idea that this can now potentially be done in doctor's offices or outside of, again, the big lab providers. The results can be available in minutes. It's a very specific option, but it's not very sensitive. In fact, we worry on the clinical side that antigen tests may miss a lot of disease. Nevertheless, if it's a way to quickly and easily rule people in, that may have certain benefit, but we have to have a plan in place for how we're going to handle negatives with an antigen test, because we probably cannot stop with a negative if we're truly worried about disease. Okay, so that was rapid fire clinical testing 101, and now I'm going to hand this over to Carolina to talk about UCSB.
Thank you, Lynn. Thank you, everybody, for having me back here. And that was a great introduction of all the possibilities that we have for testing now. So today, what I want to share with you are some of the efforts that we have taken here at UCSB to help with testing. And I must highlight that this is a very tight and nice collaboration with the Santa Barbara Cottage Hospital, where Lynn is involved in this project, and with the UCSB Student Health, who are really instrumental in this project. So there you go. So about 2 months ago, when the pandemic was first declared on March 11, I remember having a conversation with Diego, Ken, and Max in one of our offices, where it was evident that the problem was going to get very large. And it was evident that we were in deep water by then. And we decided to, or we had this urge to try to help somehow, and to use our experience, both academic and technical, to try to help for this problem. And so what we decided to do very early on was to establish the molecular tests that are necessary to detect SARS-CoV-2 in samples, those that Lynn just talked about, this in particular, the RT-qPCR here at UCSB. And the idea was to at least have an option if we needed it, at least to start looking at the reagents and to see how things were done and being able to do it in our labs. We also saw, after we started looking for reagents for these RT-qPCR tests, that the reagents were very limited and that they were hard to get. So we decided to, besides establishing the RT-qPCR, to develop a low-cost, simple, and high-capacity test. And that's what I'm going to tell you more about in a few minutes. Okay. So when we started establishing the molecular biology here in our labs for the SARS-CoV-2 testing, we faced some challenges. The tests in practice are simple. The molecular biology that is behind them, and even the handling of the samples and extraction of the genetic material, is something that we do in our lab routinely. And it's something that is not very difficult to do when you have a molecular biology lab. But again, we realized that we're hard to implement. One of the main problems was, as I mentioned, the reagents needed for the RT-qPCR assay were and are still very limited. They are expensive and they're hard to get. It was to the point that we shared some of our reagents for qPCR testing with Cottage Hospital and Public Health, because there was a time, about a month or a month and a half ago, where you could not get these reagents at all, even for testing in the clinic, let alone for testing in research labs. We also know that the equipment that is used to run the RT-qPCR test is very expensive, and as well as they are some of the point of care equipments. So we realized that not everybody all around the world was going to have anywhere between $10,000 to $50,000 to buy this equipment. And so we decided to go, can we go there? Thank you. So that, so we decided to kind of defeat the challenge, and I'm going to show you how we did this. We also have a problem with the swabs. So as you probably have heard everywhere, the nasopharyngeal swabs still are in short supply. If you want to order them, you have to wait for the manufacturer, anywhere between 5 days to 2 months, depending on where you are and who you are. And another challenge that we have here is that our research labs are not CLIA labs. We do have a CLIA lab here in the Student Health Center, and again, they are being amazing with the collaboration, and we are exploring some possibilities that we have for these CLIA labs. But what we do in our research labs cannot be reported as diagnostic tests. They cannot use our results to make clinical decisions, but that doesn't mean that we cannot run these tests. It just means that they cannot be used again in the clinic. We can use them for our own purposes and for our surveillance purposes. And I'm going to tell you how we are going to address this challenge in particular in a moment. Okay. So the first thing I want to show you is how we developed a new test. So from one of the first talks that we gave here, and now from Lynn's great presentation, you have heard a lot about the RT-qPCR. And indeed, there are dozens of modifications and dozens of places and tests that are based on the RT-qPCR that have been approved by the FDA using this emergency use mechanism. So we decided to look elsewhere, again, because of the high limitation of these of the reagents used for RT-qPCR. So we looked into another method, and there was one of these assays, one of these tests just recently approved by the FDA that are based on CRISPR. So most of you probably have heard of CRISPR for genome editing, and we had here Jennifer Dowden some time ago describing this test and also the potential of this enzyme called Cas9, which is basically a molecular pair of scissors. We use kind of a lesser known sibling of the Cas9 enzyme that is called Cas13. So what this Cas13 does is a protein that cuts RNA. If we remember, the SARS-CoV-2 genome is an RNA molecule of about 30 kbs. Cas13 can find or can be directed to any specific RNA sequence that you want, a target sequence, by using what we know as a guide RNA, which is just a small piece of RNA here. It's a 30 base string of nucleotides. And basically, this guide RNA is going to be complementary to our target. And the Cas13 is going to be guided to the target by this small molecule. Once the Cas13 finds the target aided by the guide RNA, it becomes active and it cuts RNA. And it doesn't only cut the target, it cuts any single-stranded RNA that it encounters. So we're using this approach or this ability of the Cas13 in our approach, as I'm going to show you in the next slide. So we use that property of the Cas13 to develop this assay called Cas13-based rugged, equitable, scalable testing, or CREST. So what we do in our assay is we collect our sample, we extract the genetic material of the virus, which is an RNA molecule, as I just mentioned, and then we transcribe it into DNA. DNA is easier to handle and can be amplified. So these are basically the steps that I'm showing you here: extract, amplify, and detect. We amplify this DNA molecule that now is going to be the target that we want to detect by a method that we call thermocycline PCR, or the polymerase chain reaction. This method, as I'm going to show you, is basically used by every single lab around the world that can do molecular biology. It's pretty simple, and I'm going to show you some details on that. Once we have amplified our target, we convert it into RNA again, and we detect it with the Cas13 using that guide RNA molecule that I just mentioned. When the guide RNA and the Cas13 find the target depicted here in purple, the Cas13 is activated. In our assay, we provide that Cas13 with an RNA probe that has a fluorophore in it and a quencher. When that RNA probe is intact, it's not going to emit any fluorescence. But if the Cas13 is activated and this probe is cut, the fluorophore is released and is now active, and we can detect it. It fluoresces, and that's how we know if a sample is positive or negative. And I'm going to show you that result in a moment. Our assay is very similar to the one that was approved by the FDA, developed by MIT, which is called Sherlock. But one of the main differences that we have is the use here of enzymes that are very accessible and of equipment that is very easy to use. And that's one of the advantages that we have in our method, this particular step here, the thermocycline PCR. We use an enzyme called TAC that has been off patent for over a decade, if not more, and is very cheap, it's very low cost, and it's very easy to also make in the lab. And some labs all around the world can make them. And so it's an enzyme that is not limiting, unlike the ones that we use for the RT-qPCR. We also simplified equipment, and we use these small thermocyclers that can be operated with batteries and can be even operated with your phone. So they're very, very simple. And again, they are thermocyclers that are very available in molecular biology labs all around the world. The second step, and another one of the advantages of our method over others, is the way we detect it. So as I told you, a positive sample where we have our target and the Cas13 is active is going to have a fluorescence emission after the probe here, the reporter probe, is processed. And to detect the fluorescence, usually you need very specialized equipment. But in our case, we decided to go with the simplest form that we could find. So we have this cardboard box that has some blue LEDs that are going to excite that fluorophore and are going to allow us to see fluorescence in the positive samples. It does not require any sophisticated equipment. This is really almost like a tissue box that has some LEDs inside. Here I'm showing you some results from our lab. So these 4 samples here where you see fluorescence, even in this one that is a light fluorescence signal, are positive samples, while the ones where we do not detect any fluorescence are negative. So this is a binary assay, just like a lights on, lights off assay. Lights on, you have the virus, lights off, you don't have it. So the idea behind using this kind of equipment is that these tests could be deployed anywhere. And we're looking now into collaborations with some partners in Latin America to evaluate the possibility of deploying these tests in some remote regions, like for example, in Galapagos or in the Amazonas. So again, this is very easy to do, it's very cheap, and the equipment is very simple. But it is also pretty scalable. And we can use very sophisticated equipment if we want. And that's what we're doing here, because we have the sophisticated equipment that we need to use to read the fluorescence, and we have big thermocyclers. So what we're doing right now is evaluating, oh, I'm sorry, I was gonna show you, let me see if I can do it quickly. Okay. I'm sorry that you're not gonna be able to see the video, but what I was showing you here is the automation and scaling of our tests. So what we're doing right now is, I was going to show you a picture of a nice liquid handler robot that allows us to handle a lot of samples at a time. Yeah, thank you, Lynn. I'm not sure we're going to be able to get it, but it's okay.
Yeah, sorry, I failed. Do you want to just take control again?
Yes, sure. There you go. Okay. Good. So there. So yeah, I was going to show you that we can now automate it, and we can handle several samples, or hopefully thousands of samples when we finish optimization in a day, because we're going to eliminate the need for our researchers to pipette, but the robot is going to do the pipetting for us. So this is going to allow us again to process a lot of samples. And one of the reasons why we want to automate and scale is because we see the need for testing in our community. As Lynn said, there's these efforts by the county to promote and provide testing. But again, this is going to be directed right now for people that really need to be tested in a rush, which are healthcare workers, first responders, people over 65, people with medical conditions, people working in essential occupations, and of course, people that are showing symptoms. A group that you have seen that is pretty much excluded from this effort and others around the country is those that are healthy and symptom-free individuals. And so some of our current project is going to really target that population and trying to find the prevalence of SARS-CoV-2 in this particular group of individuals. So I just wanted to remind you of the graph that Lynn showed you earlier. And basically, we are targeting people that are either in this week, so that they were infected. We are going to be able to see if they're positive or not by our method, by our assay, but they have not developed symptoms yet. So we would consider those individuals pre-symptomatic. Another line of evidence has shown that some individuals never seem to show symptoms for COVID-19, and they are fully asymptomatic, even though they carry the virus and the virus is replicated and we can detect it by PCR, but they never turn positive, or they never show manifestations of the disease. So those are asymptomatic patients. So in our cohort, we're going to be targeting, again, those pre-symptomatic and asymptomatic individuals. So what is the surveillance project that we're doing? And this is the last minute I'm going to talk. So again, we're going to monitor SARS-CoV-2 prevalence in asymptomatic individuals in our community. We are going to collect self-collected oropharyngeal swabs, and the purpose of this is to reduce the contact between our participants and researchers and minimize the contact or the possible exposure that some of our healthcare workers may face while collecting these samples. And we're going to test all samples with 2 assays. The first one is a conventional RT-qPCR, and we're using here reagents that have been approved by the CDC for testing. And we're also going to use, of course, our method developed here, CREST. This is going to provide a twofold goal. One is we're going to validate our assay. We're going to see that CREST works. And so far, we have tested in several positive and negative controls, and it works perfectly in correlation with the qPCR. And we're also going to see the prevalence of virus in our community. Very important, we're working together with Lynn and the public health department to report suspected positive cases. It's going to be important to monitor those, and the public health in the country is going to be informed of that. What was I going to say here? Okay. So we are not going to report the negative results, and importantly, I want to share with you that the first 25 samples for this project have been collected, and we will be recruiting more individuals in these short weeks that are coming. So our goal is going to be testing 1,500 individuals in our community. With that, I know that we are right on time, so I just want to thank everybody, and we will be happy to take some questions now. Thank you.
It would be delightful to take some questions. I'm afraid we've run out of time today and wouldn't be able to entertain some, but we'll be back next week with another installation, and we can get questions to our panelists when they come up. Please pass the word, and we'll look forward to seeing you next time around. Thank you.